In this audio lecture, we're going to be continuing our discussion of disorders that decrease cardiac output. And so in this audio lecture, we're going to be focusing on pericarditis. Now remember that this you can find this disorder in the cardiovascular disorder chapter. So we have this disorders that decrease cardiac output, and some general manifestations of it are going to be fatigue, so tiredness, and this is going to be to decrease the ability to transport oxygen through the body and maybe even load up our blood with oxygen. Oliguria, which is reduced urine output, and this is going to be a response of reduced input pressure to the kidneys. Cyanosis, because now we don't have that pressure to drive the blood, and so we might have more deoxygenated blood circulating through the systemic circulation. Edema, so buildup of fluid in the interstitial space, and then we could see pulse changes, right? So you actually see the pulse pressure decrease in disorders that decrease cardiac output because now we're not generating as high of blood pressure. So what is pericarditis? Pericarditis is going to be inflammation of the pericardium, just like you'll see with the endocarditis and then myocarditis. It's going to be inflammation of that tissue. Now, what happens when things get inflamed is we're going to be increasing the interstitial fluid, right? So here's a normal heart, pointer. So here's a normal heart, here's an inflamed heart where we have more blood flow going through the capillaries. We're applying more pressure, and so we actually have some more space. So we're applying more pressure due to this increased fluid in the interstitial space, which is then attracting more leukocytes. And so we can actually see that this disorder and so pericardial effusion is commonly a disorder that is associated with this, and this is the buildup of fluid inside of the pericardial sac. Okay? So this fluid can actually build up inside of this pericardial sac. Remember that the pericardial sac is the sac that contains the heart, and it also it contains a serous fluid. The serous fluid, the function of them is to reduce the friction between two different surfaces, and then also to provide some protection to the organ. In this case, it's the heart. Now, as this tissue begins to swell, because now we're increasing the amount of fluid in it, now we generate some friction. And so this pericardium actually interacts with the pericardial sac and actually becomes inflamed. And remember that when surfaces interact, and remember the purpose of that serous fluid in the pericardial sac is to reduce the friction, because any kind of muscle contraction friction would generate a lot of heat and reduce the function. And so we really want to reduce that friction. And in this case, in pericarditis, we are unable to reduce that friction. And so that is leading to some damaged parts of the heart. So what causes pericarditis? Pericarditis is really going to be caused by several different factors. So infection is probably going to be the most common cause. Usually this is begins as a respiratory infection, and then it can get to our circulatory system, causing damage to the pericardium. We could have it be from other sources that are not infective, so such as trauma. So maybe you get hit really hard in the chest, right? If you get hit hard in the chest, then that compresses your thoracic cavity so much that it applies pressure to your heart, that can end up causing an inflammatory event on that underlying tissue. Now we could have other kinds of things like thoracic trauma. These would be things like surgery, radiation, or accidents. We could have disorders of the heart already. So myocardial infarction. Okay. Maybe you have malignancy. Tuberculosis, uremia. Uremia is just an elevated urea level in the blood. And certain autoimmune conditions can cause pericarditis. So anything that can initiate the inflammatory event. So examples of those autoimmune disorders would be rheumatoid arthritis and systemic lupus erythematosus. But in this, we see that fluid shifts from the circulatory system, so right here, into the interstitial space. So this is a disorder that is associated with it, and this is called cardiac tamponade, and it's really from uncontrolled pericardial effusion. So this pericardial sac. Remember, we have the serous membrane, the visceral membrane, and then we have this underlying membrane that's continuous with the heart. Now, this lining with the heart that continuously produces that pericardial fluid. And this fluid builds up in the pericardial sac. Now, why is that an issue? Okay, how would that impact cardiovascular function? Right. So if the sac of water, you remember. So imagine going in a pool. Okay, and this is going to be a loose analogy here, but it is more difficult for you to move in that pool because it is more dense than air. Okay? And so what happens is this fluid is building up in this pericardial sac. This pericardial sac is the pool. Okay? And as it's building up in there, it's applying more and more pressure to the heart. And so actually we see that cardiac filling is actually decreased in disorders like cardiac tamponade, which are associated with pericarditis. Okay? Because now the ventricle can't actually relax enough. It's constantly being compressed by that increased amount of pericardial fluid. It decreases ventricular filling. Okay? That would decrease your stroke volume. So if you decrease how much blood goes into the heart, you decrease how much blood you can pump out of the heart. And so that's what I mean by decreased stroke volume. Now, if you decrease stroke volume, you automatically decrease cardiac output. That is, so cardiac output is equal to stroke volume times heart rate. And if one of those factors goes down, cardiac output goes down. As cardiac output decreases, now your arterial blood pressure is decreasing. And so this decreases your systemic driving pressure behind you're moving the blood through your body. So poor circulation generally follows this. Now we could have another disorder, and this is different from the cardiac tamponade, but it is still considered a result of pericarditis. And what we have is we get inflammation of the pericardium. Great. So that's inflammation of the pericardium. We know that that's an issue. But now it's the inner lining, so we're not getting the pericardial effusion, but rather we're getting friction between the outer and inner layers of the pericardial sac. And what happens is they start to rub together, and then it irritates the underlying structure. And we sometimes would undergo fibrous connective tissue development to protect the underlying structure. Right? So when you work out your garden or do manual labor with your hands of any type, you develop calluses on your hands, right? And that is a protective mechanism. And so this protective mechanism isn't really protective because it decreases the efficacy of the function here. And so if you decrease or if you increase the damage to the heart, maybe, so we're increasing the inflammation here. If you increase the inflammation, now the electrical conduction system is not going to work all that well. And then the contraction isn't going to well, because now when the heart beats, it's going to be rubbing up against something. Now, if you just rub your hands together for an amount of time, you see how warm that gets. And then just imagine that happening 70 times a minute. Okay. So we get decreased ventricular filling because now they're really this outer layer of the pericardium, the visceral epicardium here, leads to decreased filling because it now doesn't actually move as much, which decreases stroke volume, which decreases cardiac output, which decreases blood pressure. So manifestations of pericarditis include everything that you can associate with it. So pericardial friction. So sometimes you can hear this through auscultating the thoracic cavity, and it'll show up as an additional sound, and so that's called a pericardial friction, or a chest rub. And so we might actually experience some chest pain, and so angina might be commonly associated with this because now we're going to be getting really direct damage to the pericardium. Dyspnea, like I said before, is labored breathing, and that occurs because now our heart isn't functioning correctly. Right? It's not pumping the blood as efficiently through the heart or to the pulmonary circulation. Right? So the reduction in cardiac output really is indicative to the central nervous system as a decreased carrying oxygen transport. We might see that together with this dyspnea, oftentimes you're going to see tachycardia. Tachycardia is going to be increased heart rate. And the reason that the tachycardia is increased is because stroke volume is decreased. Right? So in order to maintain the cardiac output, now the heart has to work harder and it has to beat more frequently to pump the amount of blood. Palpitations, edema. So anytime you have any kind of abnormality in blood flow, it can result in edema, this buildup of fluid in your interstitial fluid. And flu-like symptoms. So things like malaise, fever, fatigue. Any of this stuff can be generally considered. And so after teaching this class multiple times, I kind of go into panic mode when I start to develop any kind of flu-like symptoms, just because I live in a world of paranoia. All right. How are you going to diagnose pericarditis? Patient history, physical examination first and foremost. Okay. So you always begin looking for those two things, and you're looking for any kind of recent infections or activities that could have led to this. Yeah. For lab tests, we're going to be looking at a complete blood count. So the complete blood count is going to tell us if there is either a recent or maybe ongoing infection. ECG is going to tell us about any kind of disturbances to the electrical conduction system. Okay. For this, you might not actually expect all that much in this case, and so really that would be a positive confirmation of myocarditis. The chest X-ray is going to tell you about the size of the heart, about the relative ratio of the different structures, and so the thickness of the myocardium, the pericardium, and maybe even look at the pericardial sac. Okay. To get a real-life picture, you're going to be going into an echocardiogram, which is using sonography to be able to visualize how the heart's pumping, and then they've gotten really impressive with their echocardiograms and ultrasound sonography. As of late, they can visualize blood flow. They can look at the amount of blood flow. It's pretty impressive. Right? Here we have a CT scan, and this is a CT scan. It's just going to be a really, really pretty and 3D version of a chest X-ray or an X-ray. And then we would also want to look at magnetic resonance imaging or MRI to get the nice 3D picture. And so that's going to tell us what we can definitely tell about the image. Now, for treatment of this, just like in myocarditis, we're going to treat the underlying causes and help resolve the issue. So we might give antivirals, we might give antibiotics depending on what's causing the issue. We'll really want to try to reduce inflammation. And so we might just give NSAIDs, or we could even give corticosteroids as that issue. Okay. So really we would want to, these NSAIDs are going to work on multiple levels to reduce pain as well, and any kind of fever that the individual is going to have. Okay. So analgesics is going to be included in those NSAIDs. Now for treatment, to continue this, we're going to reduce cardiac work, and the reason that we're reducing cardiac work is because cardiac output is already decreased, so we don't want to increase this any further. Okay. We might oxygenate blood a little bit more, provide some supplemental oxygenation to make sure that their oxygen carrying capacity is maintained. Okay. Next, we'll want to remove the pressure on the heart. So we're getting pericardial effusion, we'll want to conduct pericardiocentesis, and this is going to be removal of the pericardial fluid that sits between the pericardial sac, the visceral layer, and then the parietal layer. And so if you just pull that fluid off, now stroke volume is immediately going to go up because now venous return is going to be compromised. Okay. Pericardectomy. All right. So for a pericardectomy, we actually remove part of the pericardial sac. Right. Now the concerns with this are pretty clear, but if removing part of the pericardial sac improves cardiac function and reduces friction between the outer layer of the pericardial sac and then the parietal layer, then I think that is the best way. This is the parietal layer. I'm sorry. And so if we remove that portion of the pericardial sac, now function can actually occur, improved, but it probably won't be returned to the original level just because you're missing that frictionless environment that the pericardial sac provides. So time for hot wash now. At the end of this audio lecture, you should now be able to tell me what pericarditis is, what causes pericarditis, how does pericarditis manifest. So, and really this is where I generally focus my attention on, is how manifestations occur, because you can almost explain every single manifestation because of the physiology, right? So if the physiology is altered, how does it manifest itself? And you should be able to tell me that. How's it diagnosed, and what are they hoping to get from each of the diagnostic tests? Like, why are they doing an ultrasonography? Why are they doing an echocardiogram? Why would they measure ECG? So yes, and then how is it treated? Do they treat the whole condition? Do they treat the manifestations? What is the first line there? And so with pericarditis, we're really going to see that they're going to treat the causative factor, okay, and then they're going to try to treat the underlying symptoms and manifestations. All right, so that's the end of this audio lecture. Until next time.